Welcome to another edition of Cracking the IR Code. I am Stacie Buck, President and Senior Consultant of RadRx. So today I have chosen a case that features thrombolysis, thrombectomy, and angioplasty. And this is a patient that actually has undergone thrombolysis over the course of 3 days. And over the course of the 3 days, we also have some other work that is going on as well. So we're going to go through this report and look at it day by day. As I usually do, I'm going to start just glancing through the procedures performed list and get a feel for the types of procedures that the physician is doing, the types of information that we would want to look for when we jump into the detail of the report. So when we look at the initial procedure performed, we see that the physician is puncturing the right common femoral artery, catheter goes to the abdominal aorta, then the left common iliac artery, all the way down to the common femoral. We see imaging occurring at the different catheter placements. And then we eventually get to a catheterization of the perineal artery. And then we see step number 9, there's an injection of TPA throughout the thrombosed bypass graft that is present. The physician also does a balloon angioplasty in the graft. And then we see that the lysis catheter is placed following the injection of TPA and the balloon angioplasty to initiate that prolonged thrombolysis. So just looking at this procedure list here, what I want to pay particular attention to is that number 10, balloon angioplasty, is being performed. So what I want to ascertain here is if there's a stenosis that's being treated with the angioplasty, or is the angioplasty balloon part of the clot removal, which would then be part of the thrombolysis. So that's what I'm going to want to look for in my report. Then we see the patient returned on the next morning on April 18th, and the physician injected contrast through the indwelling catheter. There was repositioning of the catheter, and then the physician decided to continue the thrombolysis. So that's just simply a continuation. And then on the last day, again, the patient comes back, we have follow-up imaging. The physician then performs an angioplasty throughout the femdistal bypass graft, also the proximal perineal, and then an angiojet thrombectomy is performed, and then there are additional views obtained of the left leg following the procedure. So again, we see an angioplasty in the course of this procedure occurring, so we're going to want to pay close attention to the documentation surrounding that, and also this thrombectomy that was performed on day 3, because we want to determine whether or not certain procedures should be coded together. So we kind of have the lay of the land right now after looking at the procedures done in all 3 days. So let's get into the procedure detail. And so again, as I normally do, I've highlighted for you the key items in the report that you will need to determine the correct codes. So we start with a puncture of the right common femoral artery. And of course, whenever there's a puncture directly into an extremity artery, that is code 36140, but that code is going to go away as the catheter moves further. The catheter went from that right common femoral artery, you'll see, to the aortic bifurcation. So now that the catheter was placed in the aorta, that became a 36200 for the abdominal aorta catheterization, and then the 36140 was bundled with that. But we'll see in just a moment, the catheter did not stop in the aorta. It went further into the contralateral extremity for selective catheterization, so that 36200 ends up getting bundled and that code isn't assigned. So a left pelvic arteriogram was performed from that catheter placement in the abdominal aorta. And so findings are given for the common iliac artery, the external iliac artery you see there, hypogastric, and then mention that the femdistal bypass graft is occluded. So there we have a 75710 that we're going to assign for the imaging that occurred in the extremity. We have the findings that are documented right there. Then in the next paragraph, it mentions that the glide wire and the catheter were used to cannulate the occluded femdistal bypass graft and was placed with the tip in the perineal artery. So now we've reached the furthest point that the catheter has advanced to, all the way down into the perineal artery, and that is a 3rd order vessel. So that is going to be code 36247. So the earlier catheterization that occurred in the aorta and that initial access, that's all bundled with the 36247. Then from that catheter placement, more contrast is injected. Now there's an additional study of the perineal artery. The first contrast injection provided findings all the way through the bypass graft. Now this additional imaging is occurring outside of the bypass graft. And then we see that it mentions patency of the perineal artery with moderate areas of irregularity of stenosis within the proximal aspect. And there's a reason why I have that underlined in a couple of words in bold there, or a few words in bold there, because this information is going to become relevant a little further down in the procedure. But that particular imaging, we've already assigned 75710. So now we're going to use add-on code 75774. We've met the criteria for that. The catheter has been moved further, and now we also have additional findings for a separate vessel. So we will assign that. In the third paragraph here, we see now that the catheter was advanced and then TPA was infused. And then it says the balloon was deployed throughout the course of the bypass graft. And then notice I mentioned that this is bundled. The reason why I'm considering this bundled is because we don't see any documentation of a stenosis being treated here. Now, is it possible that there is a stenosis at this point in time that the physician treated? Absolutely, it's possible, but it's not documented that there was some type of underlying stenosis. So when that's not documented, then we're going to assume that the angioplasty balloon was used as part of this thrombolysis procedure in order to help remove the thrombus and wasn't actually used to treat a stenosis, okay? Because we see that this is occurring in the course of the bypass graft. It doesn't show that it actually went into the perineal artery where the stenosis was. So then we continue where it says the thrombolysis was initiated through the infusion catheter, and it was initiated at a rate of 1 milligram of TPA per hour. So now we have our initiation of our thrombolysis. So that's going to be code 37211. So because this is an arterial thrombolysis. So we have 4 codes for day 1. We have our catheterization code, we have our 2 imaging codes, and then we have the 37211 for initiation of the thrombolysis procedure. Then day 2, the patient comes back in the morning, the physician injects contrast through the existing catheter, and then that work is going to be bundled whenever there is imaging that occurs through that catheter to check the results, check the progress of the thrombolysis procedure. That's going to be bundled in the thrombolysis code that you're going to assign for that day. Whether it ends up being a continuation or whether it ends up being a cessation, that will be bundled. It mentions that residual clot was seen. Then it says the perineal artery remains patent with persistent moderate stenosis within the proximal aspect. So again, it's mentioning that it's patent, but there's a little bit of stenosis there, again, in the perineal artery. Then it goes on to say, additionally, there is a high-grade stenosis identified within the distal anastomosis of the femdistal bypass graft at the stented margin. So now we see that there's a stenosis there. So once we see that a stenosis is present, and then if we see an angioplasty that's occurring, then we're going to have the ability to report that code. So for this particular case, it would probably be worth going back and asking the physician if that stenosis was actually being targeted on day 1. But for now, I'm not coding it because it's not clearly documented. So for day 2, what we have is we have a 37213. The only thing that was done that day was the thrombolysis check. The contrast was injected, nothing to check, the progress. Nothing else was done on day 2. So it's merely a continuation, which is 37213. All the work that was done that day is bundled into the 37213. The patient comes back now on day 3, that morning of 4/19. And then there's an injection through the thrombolysis catheter. And again, that work is going to be bundled. And now here we see that it's mentioned again that the bypass graft has multifocal areas of stenosis. So now we see, again, clearly documented areas of stenosis in the bypass graft. And then it goes on to say that balloon angioplasty was performed throughout these areas. And then it also mentions doing balloon angioplasty of stenosis within the proximal perineal artery as well in this particular report. And then again, it mentions the persistent area of stenosis was seen at the distal aspect of the stent, at the distal aspect of the bypass graft. So here in this paragraph, we're assigning a 37224 for for the angioplasty that is occurring because we see an underlying stenosis being treated. Now, what isn't clear is whether or not these were separate lesions treated in the bypass graft versus the perineal. It could be continuous. It could be from the bypass graft into the perineal, potentially. So there isn't, another code to assign. If there were separate and distinct lesions treated where one was specifically in the bypass graft, that's 37224. If there's a separate and distinct lesion in the perineal that would not be related to this, then you could also pick up the code for the perineal, the 37228. But again, the documentation doesn't have the clarity for the additional code. Once again, you could go back and you could ask the physician and potentially add that code. Then when we see the second paragraph there on day 3, it says repeat injection of contrast demonstrated some residual thrombus within the perineal artery, which propagated, causing occlusion. And then it goes on to show that the physician did a thrombectomy. So the question that would arise here is when we're coding the thrombectomy, should we code this as a primary, a 37184, or should we code this as a secondary, a 37186? So I will tell you why I chose the 37186. The reason why I chose the 37186 is because there was not, in all the prior findings, it was never mentioned that there was a thrombus in the perineal artery. It mentioned that it was patent, and then there was a little bit of stenosis. So because this seems to be a new finding in that artery, then I went with the 37186 versus the 37184. If it had already been an issue and there had been something documented prior in the perineal, a thrombus, and then the physician was going to treat that, if we had been following this case through and it was thrombus, 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 then I would have probably gone with the 37184 if the documentation supported that. So that's my rationale for choosing the 37186. So that's a sign for the angiojet thrombectomy. And then you'll see that ultimately flow could not be restored, but the physician decided to terminate the procedure. So now we have our last day of thrombolysis, which is going to be reported with 37214. And then you'll note that I have a modifier 59 on there because that code will hit an NCCI edit with code number 37186. So I'll just go down to the last page here and show you the summary. So day 1, we have our catheterization and imaging with our initiation of thrombolysis. Day 2, we had our continuation. Day 3, we have our thrombectomy, and we also have the angioplasty that was performed for clearly documented stenosis. And then the thrombolysis came to an end that day. And then I just added some comments into the document for you, just to give you reminders of why we chose the codes that we chose and why we didn't choose certain codes. So hopefully you found this case helpful. Not only did you pick up some coding tips and pointers, but also gives you some food for thought on the types of information that you should look for in the report, and also questions that you can take back to your physicians, and different things that you can query them on to make sure that you're getting complete and accurate documentation. So thanks for tuning in, and I'll be back again in 2 weeks with another case study.